Hello, thank you for joining us for this very special class on cancer and genetics in honor of Breast Cancer Awareness Month in October. My name is Lauren Elliott. I'm the Director of Communications and Community Engagement here at HCA Florida North Florida Hospital. It is my privilege to welcome Danielle Rogers, who is our oncology genetics specialist here at the hospital. And she's going to give an incredibly informative presentation on cancer and how to and your genetics and how the two are interconnected. So Danielle, I'm going to go ahead and hand it over to you. Before I do that, I'd love to ask everyone to go ahead and mute your lines at this time. And what we're going to do at the end is we're going to ask everyone at the very end if you go ahead and hold your questions until the end, or you can place them in the chat as we're going along and we'll answer them at the end of Danielle's presentation. And I will be monitoring those questions and I'll let Danielle know at the very end. So please put your questions in the chat where you can hold them and ask them verbally at the end. So Danielle, go ahead and take it away.
Yes, thank you so much for everyone for attending. So today, in honor of Breast Cancer Awareness Month, I'm going to focus on hereditary breast cancer, talk about associated risks as it relates to genetics, family history, personal risk factors, and talk a little bit about the history of breast cancer as well. So I'm going to go ahead and share my screen. Let's see. Okay, can everyone see that okay?
Yeah, thank you.
Okay. So this is just kind of a little general overview of the different cancers that we can see that can be associated with hereditary syndromes. I know today we're mainly focusing on hereditary breast, but it is interesting to see as the realm of cancer genetics evolves, we find that there are many hereditary predisposition syndromes. And, oftentimes patients may carry a genetic risk for disease and not realize they have it either due to absent family history or, differences in penetrance of some of these mutations. So, trying to gather as extensive of a family history as you can be very helpful. But oftentimes with genetic testing now, because we're looking across a multi-gene panel or pan cancer panel, we may oftentimes find mutations that may actually have no correlation with what we're observing in the family history, but can still have implications for screening and survivorship as well. So this is really just to overview some history of breast cancer. So, honestly, breast cancer, we can have documented going all the way back to the ancient Egyptians. There was an ancient Egyptian medical text called the Edwin Smith Papyrus, where they actually described cases of breast tumors that they were treating with cauterization. So this is not something new. It's just our way of treating it, and our evolution in treating it has improved. Of course, Hippocrates is who gave the name cancer, so it does go back as far as ancient Greece. But just to kind of give a little bit of history, there are some famous people in history where breast cancer did touch their lives. Anne of Austria, the Queen of France and regent to King Louis XIV, actually had her documentation or her case of breast cancer being documented illustrating, early invasive surgical interventions, when they started to address this with surgical procedures. And they actually treated her breast cancer by applying an arsenic-based paste followed by removal with razors. Thank God where we are today that we are not doing that anymore. Of course, there is documentation of Abigail Adams Smith, who is the daughter of John Adams, one of our founding fathers, who was diagnosed at an early stage with breast cancer. And the surgeons who performed her surgery, her mastectomy at that time, actually documented the case in a medical text and even commented on her stoicism as she did undergo the procedure with absolutely no anesthesia. Unfortunately, she passed away from metastatic disease within a year of her diagnosis. And just to kind of give a little bit of history, I'm sure you're seeing there in the bottom left-hand corner, there is a picture of Adolf Hitler. This is really more to talk about his mom's history of breast cancer. She died before the age of 50. She was in her 40s when she was diagnosed. At that time, Adolf Hitler was around the age of 18 or 19 and apparently loved his mother very much. And this is really more just to talk about the impact that we do make in patients' lives. Things that we do matter. Because if you notice to the right of Adolf Hitler, that is Dr. Edward Block. He is the doctor who cared for his mother, and he was of Ashkenazi Jewish ancestry. Just at the start of World War II, Adolf Hitler actually found Dr. Edward Block and his family and granted them safe passage to the United States. So it is kind of confounding when you realize someone like him who was persecuting the Jews, that he would save someone who obviously took very good care of his mother and he respected. So just a timeline of hereditary breast cancer. So the first documented mention of a possibility of a familial breast cancer was with Dr. Paul Broca, who's really known in the neurology aspect of medical history, but he observed a significant family history of breast cancer, primarily in his wife's family. I think there was about 8 or 9 women with breast cancer. And at that point in time, he did kind of indicate that maybe there is some familial connection to breast cancer. However, we did not know what that was exactly at that time. In the late 1800s, early 1900s, Dr. Alfred Scott Borthen actually followed a family that he called Family G. This was the family of his seamstress, where there were documented cases of multiple related cancers going back through generations. And I think since 2005, there has been about over 900 descendants from that family. And this was looking at cancers primarily that, were colon, uterine, as well as some other gastrointestinal cancers. Now, what's interesting is we did not identify this family's mutation until the early 2000s. So it is interesting to see that we do have medical texts going back to these families. Now, in 1953, there were 4 scientists, Francis Crick, Rosalind Franklin, James Watson, and Maurice Wilkins, all co-discovered the double helix structure of DNA, which really has brought us to where we are to help understand genetics and how it impacts our health, as well as treatment and medical management. What's interesting, though, is Francis Crick, James Watson, and Maurice Wilkins all received the Nobel Prize in Medicine and Physiology. However, Rosalind Franklin, unfortunately, was not able to obtain this as they were not doing posthumous recognition. Unfortunately, she passed away in her late 30s due to ovarian cancer and was also of Ashkenazi Jewish ancestry. So it makes you wonder, did she potentially die from a hereditary ovarian cancer syndrome before we even knew what that was? But definitely her contribution to medicine has led us to be able to offer testing and save countless lives. Moving forward in the 1960s to 1970s, Dr. Henry Lynch, who is coined as the father of cancer genetics, picked up Dr. Alfred Scott Borthen's research and actually completed gathering that family history from Family G. So it really has been helpful to give us an idea of understanding these different familial patterns, especially with some of these more penetrant or higher risk genetic syndromes. He was also on the team that co-discovered the first BRCA1 mutation. And of course, Marie Claire King, who is very well known in the BRCA arena, as far as contributing her science and research to understanding and discovering the BRCA1 mutation as well as BRCA2 mutation. She is noted for saying that, offering genetic testing to a woman only after she has been diagnosed with breast cancer is a failure at prevention. So she has been a big proponent at offering population-based testing to try to identify people who are at risk to try to implement preventative care and strategies. So first thing that I'm going to focus on, of course, is the genetics aspect. I will say that there are other common risk factors for breast cancer. And just before we get into that, hereditary cancers, especially hereditary breast cancer, really only accounts for about 10% of cancers that we diagnose and treat. We do know that most breast cancers occur sporadically. So, I do want women to know that even if you don't have a family history, you can still get breast cancer. It is important to adhere to screening. We know that increasing age is the big risk factor for breast cancer. However, genetics can sometimes determine if someone is at a risk for developing this at a much earlier age. Of course, family history still matters, even when our genetic testing is inconclusive. So we will discuss ways to screen patients who may have a familial risk, even when the genetics anomaly is unknown to us. We do know there's personal risk factors such as breast density or findings of abnormal breast biopsies. There can be what we call proliferative changes in the breast that can be associated with an increased risk. We do know young people, young cancer survivors who may have had radiation to their chest wall, such as Hodgkin's lymphoma cancer survivors can have a risk for breast cancer as well. So this is just a nice little acronym. This was provided to us by one of our genetic laboratories, where it just kind of helps you to understand who's appropriate for genetic testing. So they use the acronym MARY, M standing for multiple. So this can indicate someone who may has personally had multiple cancers in their lifetime, say a woman with bilateral breast cancer, someone with breast and ovarian, or let's say someone with colon and uterine, or you may have multiple family members on one side of the family. So if I have an individual who reports 3 close family members with breast cancer, specifically maternal or paternal, that meets criteria for testing. And of course, multiple polyps is one thing that we look at, especially 10 or more polyps in an individual person's lifetime can also meet. Of course, A stands for ancestry. We do know that people of Ashkenazi Jewish ancestry do have a higher prevalence of certain founder mutations. That's why I mentioned that about Rosalind Franklin being of Jewish ancestry. So we definitely offer genetic testing in patients who come from high-risk ancestral groups, as well as who reported personal or family history of cancer. And then, of course, R stands for rare. So these are cancers that are not as commonly occurring compared to sporadic cancers. We do have common cancers such as female breast, prostate, lung, colon that occur in the general population, but some cancers are less commonly occurring, but can be seen often in these hereditary syndromes such as male breast cancer, ovarian cancer, pancreatic cancer, and of course, we do offer testing for metastatic prostate and metastatic breast cancer as well. And then Y stands for young. We know in sporadic cancer cases, it's really more common to see cancers over the age of 50, again, because of course, increasing age is a risk factor. But when we see someone diagnosed at a younger age than we would anticipate, it may warrant investigation of a potentially hereditary syndrome that could be the causative factor or be an attributing factor. So this is just an overview. Oftentimes when we talk about hereditary breast cancer, many patients and providers may be familiar with BRCA1 or BRCA2 or what we reference as BRCA. I like to refer to them as the poster children for hereditary breast and ovarian cancer. And they do account for the majority of mutations that we identify in genetic testing. But over time, we have identified mutations in other genes that kind of live in that same DNA repair pathway or DNA repair pathway neighborhood with BRCA1 that can also be associated with hereditary breast cancer risk. And you can see these are over here, including CHEK2, PTEN, ATM, TP53, CDH1. There is some emerging evidence looking at Lynch syndrome, Dr. Henry Lynch, who followed family G, which is primarily a colon and uterine cancer syndrome, but we are starting to look at maybe a slightly elevated increased risk for breast cancer in those patients, PALB2, STK11, BRIP1, and some others as well. So just kind of wanted to give y'all an overview. And you can see if you look on the left-hand side, the hereditary cancers, breast cancers really only account for about 10 to 15%. Most are sporadic, or maybe there is a genetic mutation that is just unknown to us at the present time. This just kind of gives you an overview of the screening guidelines for patients who do test positive for some of these mutations. I have put the highest risk genes and medical management guidelines at the top, and it kind of goes down through moderate to lower risk mutations. Now, all of these mutations do carry a higher risk than the general population risk of 10 to 12%, but you can see specifically with TP53 is a significantly higher risk for breast cancer at young ages. We do start MRIs, breast MRIs at age 20, and try to incorporate mammograms at 30. Part of the reason why we try to hold off on mammograms is that these individuals do have a really high sensitivity to radiation exposure because of their risk of certain cancers. So we try to avoid radiation exposure at all cost. With BRCA1 and 2, you can see MRIs start at 25, mammographies are postponed until 30. And then as you go down through PALB2, PTEN, you can see the ages at onset kind of change, as do the surgical management. You notice not all of these gene mutations is there a strong indication to offer women preventative mastectomy or preventative surgical removal of their breast to help prevent breast cancer, because again, the risk is so moderate and maybe lower than what we initially anticipated. So again, these have to be stratified based on that individual patient's risk factors, their family history, and the mutation that's involved. So I know this is a busy slide, but just kind of wanted y'all to see the differences in risk, which you can see are highlighted in yellow between each gene mutation. So really wanted to talk to you all because since we did that little overview of the MARY acronym, this was an interesting study. Dr. Allison Curian and her colleagues looked at tumor registries in the state of California and Georgia between 2012 and I think it was 2021. And they were specifically looking at the uptake of genetic testing based on certain cancer diagnosis. Now, if you remember in the MARY acronym, R stands for rare. The reason why that's important is because anyone with a rare cancer, male breast cancer, ovarian cancer, pancreatic cancer, they should all undergo genetic testing regardless of family history. So you would expect especially in those cases that would be 100% uptake. But what was really interesting is during this time and evaluating these records, she found that the only one that met a 50% threshold, so only 50%, was male breast cancer. So none of those rare ones even meet at 100% threshold, even though they were 100% appropriate for genetic testing. So that was really eye-opening to realize that we are missing opportunity to offer patients genetic testing, to identify patients who do have hereditary syndromes and offer cascade testing to their family members. Because again, this is not just about an individual patient. This is about this patient and their family, and we can certainly offer opportunity to prevent cancers. I would say this has probably improved slightly, but I'm sure that there's much more work that we can do to try to improve the uptake of genetic testing. And this might be part of the reason why Dr. Marie Claire King was such a big proponent of population-based testing, because it will help to eliminate missing some of these at-risk individuals. So how we change lives with genetic testing, of course, this can offer patients the opportunity for earlier screening. Technically, when you look at the recommendations for average risk women, mammograms should begin at age 40. However, women who may have a genetic predisposition are going to need earlier intervention. So we want to try to implement that as early as possible. So if they were to develop an early onset cancer, we would have a higher likelihood of finding it at an earlier stage, which is going to improve overall survival. Of course, early detection, which I approached on prevention. As mentioned, some of these genetic syndromes, you can offer preventative strategies such as risk-reducing hysterectomies for a risk of uterine cancer, risk-reducing surgery to remove the ovaries and fallopian tubes to reduce ovarian cancer, risk-reducing mastectomies to help reduce the risk of breast cancer. And then, of course, risk reduction. Some patients may be appropriate for certain interventions such as tamoxifen or anastrozole. These are certain endocrine therapies that can help control estrogen proliferation in the breast and help reduce breast cancer risk. And then, of course, I always say that we like to create previvors instead of survivors. We want to give people an opportunity to not have to become a statistic, to be able to eliminate worry or concern, especially if they have a strong family history. And then, of course, this helps patients understand their risk and gives them the choice to decide how they want to manage their risk. It's one thing to offer patients testing, inform them, and they decide against it. That's completely their choice. But if a patient is never aware that they have a risk in the first place, or that they have opportunity to evaluate that risk, then they never have the opportunity to mitigate it as well. And then, of course, we want to help prevent disease in their family members. And then, of course, connecting patients with trials, registries, and peer support is very important. And of course, through trials and research, we'll be able to hopefully find ways to continue to protect these families and individuals as well. Costs for genetic testing. This often comes up. Genetic testing sounds expensive. Many patients and providers, always cringe, like, oh, this is going to cost thousands of dollars. I can't afford it. I don't want to do that. And we actually know that the cost of genetic testing has become more and more affordable over the years. Many insurances, in fact, I would say most, have coverage policies for genetic testing. That's usually based on personal history of cancer or family history. But I will say a lot of the genetic laboratories have been able to drive down the cost of their testing to offer patients even cash prices as low as $249. And that is important too, to understand that, most people are not having to pay an exorbitant amount of money for their genetic testing. The thing also that I like is many of these genetic laboratories, if you find a mutation, is actually offering free cascade testing for their family members. So you can actually give their family members access to testing when an identified mutation is there, and help remove that barrier so that they don't have to worry about financial toxicity or any out-of-pocket cost as well. And what was interesting, there was a cost effectiveness microsimulation study that looked at over 11,000 women. And of course, these were all women with a diagnosis of breast cancer. And what they did is they were like, we're going to test all of these women for, BRCA1 and 2, as well as PALB2. And then, of course, they tested women who met clinical criteria. And this was for women in the UK and the US. And so what they found is by offering all of these women with breast cancer genetic testing, either with a family history or without, that they found that they could technically prevent over 2,000 cases of breast or ovarian cancer and 633 deaths in the United Kingdom, and over 9,000 cases of breast and ovarian cancer and over 2,000 deaths in the United States, just by opening that window to access to testing. So a lot of facilities, are considering that. Some people test all women with breast cancer regardless of family history. Some people adopt 65 and under, because we found through studies that the yield of finding a mutation over the age of 65, especially if there's not a significant family history, is very low. So again, this is something that we continue to revisit and look at. So let's talk about family history. I tell people hereditary breast cancer only counts for 10 to 15%. But when you think about people who pursue genetic testing, that means only 10 to 15% of them are going to come back positive. The majority of the people we test are going to be negative. But family history still dictates how we manage these patients. And family history of breast cancer is very important because we do know that women who have a first-degree relative or multiple close relatives are felt to technically be at a higher risk for breast cancer. So one of the ways that we try to help estimate or help to guide medical management for women with a strong family history is through something called breast cancer risk assessment. So this is a really kind of a calculation that we're able to perform. And so for some of you, if you're already doing mammograms, you may have recalled when you go into the imaging center, they have you complete a questionnaire, which asks you all kinds of crazy questions, such as what is your height and weight? How old were you when you started your periods? Have you had children? How old were you when you gave birth? Have you had a breast biopsy? Who in your family have had breast cancer? This is all so that they can put this data into that risk assessment. And what it does is it kind of computes what that woman's estimated lifetime risk is for breast cancer based on personal risk factors and combined with family history. And the reason we do that is because when we can incorporate that, any woman who has a calculated risk at 20% or higher should be considered for enhanced surveillance per current evidence-based guidelines. And these surveillance recommendations really are the same screening protocol that we offer women who come back genetically positive. So there may be women who are still at a higher risk. They may not have a genetic mutation per se, but can still qualify for significant screening. And you can see these are several societal guidelines that recommend breast cancer risk assessment. I will say the Society of Breast Imaging, or SBI, specifically recommends that all women of Jewish ancestry and African American should undergo baseline breast cancer risk assessment at age 25. So the thing is we're doing this in women who are coming to the imaging center. So that means either they're 40 and at screening age, or they're having some issues or starting early. But what about the women who maybe aren't going to an imaging center yet? They're 20, they're 25, they're just starting getting connected with gynecologic screening. These are the women we want to try to capture so that if there is a chance that they could have a genetic risk, we could hopefully identify breast cancer instead of it being advanced stage. And unfortunately, oftentimes these young women who are not aware of their genetic risk or their family history, or that they should be starting screening younger, when they are diagnosed at young ages, it oftentimes can be locally advanced. So it can be in more advanced stage 3 or even stage 4. So we want to try to make sure that we're getting these patients the correct information. So this is just kind of a picture of what some of these risk assessments look like. The one on the left is really what we call the Tyrer-Cuzick. It's just one model. You can see this woman's lifetime risk is at 20.82% compared to 8.8% in a woman her same age in the general population. And it gives her a residual lifetime risk. Currently this woman is 47 years of age. So we're looking at what is her risk from 47 to 82 or 85. And of course, the person on the right has only about an 18% lifetime risk. So not really meeting that 20% threshold that we would use to consider supplemental screening, meaning we need to add more than just one mammogram a year. We need to incorporate other screenings such as breast MRI, our contrast enhanced mammography, or, other modalities. So we're not just relying on one way to screen these women each year. So some of you may know who this is. She is a famous actress. Her name's Olivia Munn. So Olivia apparently had some family history of breast cancer. She went in for a screening mammography, which was normal. She completed a risk assessment questionnaire and was found to have a lifetime risk of, I think, about 37%. So she was recommended to undergo a breast MRI because they realized her risk was higher than the average woman. She needed supplemental screening, so that is usually the preferred supplemental surveillance. And the breast MRI actually detected her breast cancer at a very early stage. So she definitely attributes breast cancer risk assessment and the person, whoever did it, taking their time to consider her family history and her personal risk factors, because she does feel that that was life-saving, because her mammogram, again, did not detect her breast cancer. It was her breast MRI. And this is just a quick picture of one of the screening guidelines that we can use, or that we use often. You can see women who have a residual lifetime risk at or greater than 20%. If you follow the arrow over, it says definitely consider annual screening mammogram, but you should also incorporate annual breast MRI or other modalities, which you can see below that, such as contrast enhanced mammography, molecular breast imaging, or whole breast ultrasound. So let's talk about breast density, because a lot of women who are getting mammograms are being notified with their results whether or not they have dense breast tissue. And dense breast tissue is very common. It does not mean that anything is wrong with you. This is something that some women are just going to have a more compact glandular tissue. You can see the breast is primarily comprised of fatty tissue, which is kind of this dark orange and light orange. And then, of course, we have what we call these lactiferous ducts or milk ducts, and of course, the milk glands towards the back of the breast. Now, typically we assume as women age, removal, from hormones through menopause, that our breast density kind of changes over time. And that may be the case. We know weight fluctuations can affect breast density. Of course, genetics can as well. But the reason why this is important is because the denser a woman's tissue is, it kind of decreases sensitivity of mammography. So we want to know if women have certain personal risk factors. And the thing is we want to understand the limitations of what our current screening is. There are laws out there now that are looking at coverage for supplemental screening for women specifically with dense breast tissue. So again, this has nothing to do with family history. This is more of a personal risk factor. And we will go over that as well in a minute. But I just wanted to kind of show you the 4 different categories of density. Of course, over to the right, extremely dense, that is a very, very dense breast there. Heterogeneously dense would be the next. The 2 on the left-hand side are not necessarily considered dense breast tissue, so those are not felt to be as much of a concern. It doesn't mean that women with fatty replaced breast or scattered fibroglandular density cannot get breast cancer. Any of these women can, but it just gives you an overview of what we're looking at. So this is really a mammogram image of 4 different women's breasts with 4 different levels of density. So again, going to the far right, this woman is an extremely dense breast tissue. You can see all of this kind of white conglomerate. This would be a breast that would be very difficult in cases to find maybe even a small breast cancer. It could easily be hidden. So this is why we want to recommend supplemental screening, because we want to consider the limitations of mammogram, which is standard of care, because again, maybe offering a supplemental surveillance may find a cancer that the mammogram could miss. And of course, the heterogeneously dense tissue here. Like I said, there's legislation in place. There are some states who cover supplemental screening for patients, especially when we talk about coverage for supplemental screening. It's not so much about getting an authorization. It's going so far as to say, if these women have this specific risk factor, how can we pass laws to help coverage so that they're not having to be expected to pay a copay or co-insurance? So kind of get it covered under a preventative screening kind of protocol, because I will say that is a big hindrance for women who are considered high risk, is one, imaging fatigue when they're having to go so often, but also potential out-of-pocket costs. Breast MRIs are not cheap. And depending on the type of insurance you have, your co-insurance could be hundreds of dollars. That may be the decision between, can I pay my light bill or have a breast MRI? So we are trying to do that. And I've put a couple of websites here below that you can go on and look. There's lots of helpful information. They even have information on advocacy, as well as templated letters where you can write your local legislator to try to get laws passed so that women can have access to, the appropriate screening based on, their risk factors. Now, this is just a map of the United States. You can see the ones in green already have some laws in place for coverage for supplemental screening for women who are at high risk, who have dense breast tissue. Of course, it doesn't mean that they're 100%, like all insurances in that state are being covered, but it does tell you like where we're heading. Obviously, people are starting to pay attention to that. On this next slide, I just kind of highlighted. So for the state of Florida, effective January 1st of 2026, supplemental screening for women with dense tissue will be covered with no expectation of coinsurance or copays in women who have the state health benefit plan. So again, it's just for those with the Blue Cross Blue Shield state health benefit plan. But again, we're getting somewhere. Hopefully other insurances will follow suit. But again, it will take us advocating for ourselves and other women to try to get more coverage with insurances and get more laws passed by state. I have a quick video, Lauren. It's only about 3-4 minutes long. Is it okay if I try to play that?
Absolutely, please.
Okay.
Clothes are folded. Feel weird wearing this gown, and the air conditioner is a bit too strong.
What I would recommend is pausing that video, go ahead and stop sharing your screen here,
I am,
and
yeah,
then
that's exactly what
share
I
the
was doing. Yes,
perfect.
yeah, I was doing that. Okay. Yeah, I was trying to move it over so I could.
Find yourself waiting here. Clothes are folded, feel weird wearing this gown, and the air conditioner is a bit too strong. It is moments like this where you could change everything. No, not like that. I mean, for your health. How? Simply just by asking questions. You and your doctor are a team. Team your health. And if your team's gonna win, then you need to get in the game. Right. No more sports metaphors, I promise. Here are the top questions to ask your doctor about breast cancer. Number 1, does my family history matter when it comes to breast cancer? The more people in your family who've had it, the younger they were when they were diagnosed, and the closer they are related to you, the higher your chances are of getting it. If you have a strong family history, ask your doctor about genetic testing. It's really important. Family history raises your risk of breast cancer, but even if you don't have breast cancer in your family, you're still at risk. Number 2, do I have dense breasts? Half of women over age 40 have dense breast tissue. It's natural and normal. Density matters because dense tissue looks cloudy on a mammogram. This means cancer is really hard to see. For women with dense tissue, mammograms without other screenings can hide up to 50% of cancers. Not great. On top of that, dense tissue makes it 4 to 6 times more likely that you will get breast cancer. You can't tell if you have dense breasts by how they look or feel. The only way to tell if you have dense breasts is to have a mammogram. Which leads us to our next question. Number 3, do I need more than a mammogram? Some women need screenings in addition to a mammogram, like if you have dense breasts. On an ultrasound, the dense tissue is still white, but the cancer is black, making it easier to see. For people with very dense tissue, an MRI might be the right tool. It's like the superhero of finding cancer. In some states, insurance must cover breast ultrasound and MRI. If yours doesn't, talk to your doctor or navigator for next steps and options for support. Asking your doctor about these essential tests in addition to your mammogram could save your life. Number 4, how often should I get screened and what tests do I need? Early detection is the key to fighting breast cancer. If you find it early, you have a 95% chance of beating it. So talk to your doctor about screening every year starting at age 40 if you're at average risk. And earlier if you have other risk factors. Not all doctors agree on when to start and how often. The data shows that starting at 40 will save the most lives. It can be a game changer. Probably thinking, I'll never remember everything I learned today, and you're probably right, which is why we wrote all this down for you on a webpage. This whole video, this set, these lights, the camera guy, the props, the Brem Foundation, this whole team have come together to make this video. And we did this for you. And that's because you are the key to pushing back on breast cancer. Early detection is so powerful, it could save your life. If you get engaged and, dare I say, get in the game, you could change everything. So be brave. Ask these questions, and if you forget, visit breasthealthquestions.org for a free downloadable list. Lastly, share this video with someone you love.
So,
Hi,
oh,
I'm going to talk today about the kind of questions you should be asking your medical team if you or a loved one are going through treatment for breast cancer.
let me. Oh gosh.
It's important to ask questions for a couple of reasons. One,
Okay. Sorry about that. Okay. I apologize. That was kept playing. So, getting back to the end, I apologize, y'all. So these are just a couple of programs that are out there trying to get legislation passed. So you can definitely check that out. Find it Early Act, the National Breast and Cervical Cancer Early Detection Program, as well as the Access to Breast Cancer Diagnostics. The Brim Foundation is actually from Dr. Rachel Brim, who is a breast radiologist. She had a family history of breast cancer. In fact, her mother passed away at a young age, and she detected her breast cancer when she was trying out a new technology in her imaging center. So she has definitely been a big proponent, also being a cancer provider, but also herself being a cancer survivor. So that was from her website. And then, of course, this is always my favorite cartoon to share at the end of any of my presentations because it definitely speaks volumes. So you can see our lovely little old man there at the pearly gates pretty much says he'd have been here sooner if it hadn't been for early detection. So the end. Any questions?
Danielle, thank you so much. So everyone who is attending the call, if you have any questions for Danielle, you can go ahead and put them in the comments here in the chat, or you can go ahead and unmute yourself now to ask Danielle your question. Hi, Becky. Are you trying to ask a question? You
Yeah.
came on. Perfect.
Can
We
you
can hear you now. Perfect. Go ahead.
testimony? Okay. I just have a testimony. It started off with a breast cancer screening, but Danielle saved my life and 4 generations of my family, and through genetic screening. And there is 9 of us that are on a watch and have had surgical procedures, and we will all always be forever grateful to Danielle and this screening process. And if anyone ever wants to know any details, you let me know. I'm grateful.
Thank you, Becky.
You're welcome.
That's awesome. Thank you so much for sharing. Now, before we move on to another question, we have a question that's coming in the chat here from Charlene, and I think this is from maybe a healthcare perspective. So how can we use this information to help the patients we navigate, Danielle?
Yeah, perfect. So, Charlene, I know that y'all navigate patients with breast cancer. So again, it's kind of going back to that, whole concept of who should have genetic testing. Again, I feel like, every woman 65 and under should be offered genetic testing. Of course, women with a family history. The other thing that might help, because I know as navigators, you do get a little bit more one-on-one time or more intimate time with the patient, is, kind of taking the opportunity to dissect their family history. Oftentimes when we go to our doctor's office and we're asked, what's your family history? We're kind of in a pinch. We're overwhelmed, especially our cancer patients. I mean, their whole world has been turned upside down. They're just trying to process the information, and then they're asked 20 questions. So sometimes remembering or recalling all the family history may not happen in one visit. It may take somebody discussing this with them over and over again. So as navigators, you have a unique opportunity to really go, hey, let's talk about your family history, because you might have a woman who, hey, she's 67 with breast cancer, but what if you find out she's adopted? So she doesn't know her family history, but anyone else would have looked at that and said, oh, she's 67, no family history. But really she doesn't know her family history. Or let's say she has what we call a truncated family tree. Maybe her mother died in her 30s in childbirth. There were no women on that side of the family. So you have kind of a limited female structure. So it's kind of being able to tweak some of those things that could easily get missed in the clinic, especially in our cancer patients. But the other thing is helping patients to know the importance of genetic testing. I know there are some cancer patients who are afraid to do genetic testing. Sometimes they'll say they don't want to know, but they don't understand the implications this can have for their future surveillance. They could prevent second primary cancers. When you think about women who may have a genetic risk for a second breast cancer or ovarian or colon, there's things that we can put into place in those survivors to help reduce the risk of that. The other thing is helping them understand this information can help their family members, their children, their grandchildren, their siblings, their nieces and nephews. So it's just really being able to try to alleviate a lot of concerns, dispelling a lot of myths that these patients may have. And like I said, as navigators, you do get a lot more intimate one-on-one time with the patients. And I think it would be very helpful and fruitful. And you will see the fruits of your labor, I can promise you, at any imaging center that has implemented genetic cancer risk assessment, any high-risk clinic, you will see that there will be lives saved in people's lives improved for the better half of it.
Charlie, thank you so much for your question. Does anyone else have any other questions for Danielle at this time? Well, great. Thank you guys so much for joining us today. And Danielle, thank you so much for being available and for giving this fantastic information to our community. We greatly appreciate it. And we wanted to thank all of you for taking time on your Thursday afternoon to take this class here at HCA Florida North Florida Hospital. So thank you very much and have a great rest of your day.
Thank you.